Good afternoon, everybody, and welcome to this new webinar of the ERN Reconnect. It's for me really a great pleasure to introduce you our speaker today, Professor Albert Selva. He is a professor in the University of Barcelona and a senior consultant, especially in inflammatory myopathies, but in internal medicine in one of the largest hospitals in Barcelona, in the hospital Vall d'Hebron. He is a full professor, and he has had very big responsibilities. He's now the dean of the medical school there in Barcelona. But over all these titles, but for me, the most important is that he is one of the best experts for me in the world on inflammatory myopathies. I know he knows by heart everything about the phenotypes and with the different antibodies in inflammatory myopathies, and is the person I always trust, and I always comment my very difficult patients. So Albert, please, when you are ready.
So thank you very much for your kind words, Patricia. As you can see, she's a good friend of mine. But today we're going to talk about the autoantibodies in patients with inflammatory myopathies. Thank you again for all the people who is listening, who is seeing the webinar, for joining us. And the title is, as said, autoantibodies in inflammatory myopathy. The first thing that we have to keep in mind is that inflammatory myopathy is a systemic disease. Of course, that muscle may be involved, as you can see here, with some difficult muscle weakness and also dysphagia and skin lesions with this heliotrope rash and the Gottron papules, but other organs, organs such as the heart or the lung, in a severe way, may be also involved. Other challenging manifestations, such as milk calcinosis, as you can see here, may also appear in these patients. So it definitely are not only a muscle disease. Of course, the muscle is important, but they are systemic diseases. Of course, if there is muscle weakness, muscle biopsy helps a lot the clinicians to diagnose these patients. You can see here the characteristical vacuoles, remed vacuoles of IBM, or this perifascicular atrophy and infiltrate of lymphocytes in dermatomyositis, or also in the differential diagnosis, as you can see here, in a patient with a myocardial disease who has been diagnosed some years ago with a polymyositis. Of course, the diagnosis was not correct. You can see here the pus positive deposits in the muscle fibers of this dystrophy, dysferlin, and also mitochondrial myopathy with these ragged red fibers. So it is useful for clinicians, the muscle biopsy, but as I said before, it's not only the muscle who is affected. So we have the muscle biopsy, we have the clinical grounds, but today we're here to talk about the autoantibodies. You can see here in these very nice pictures the different autoantibodies that have been described until now, and the clinical associations. You are here immune-mediated necrotizing myopathy, related with a statin or not, with SRP. We are going to talk about some of these phenotypes which are related, linked, or associated with these autoantibodies. But we have to remember that the first researcher that report a clinical phenotype in relationship with the autoantibodies were those researchers from Baltimore, Professor Fred Miller and Professor Lori Love. They identify here at least 3 phenotypes. You can see here in blue the antisynthetase syndrome, which was positive to anti-SHO1. The other autoantibodies were not known in this 1992. That was the year that was published this paper. Another phenotype mainly with muscle involvement, not so systemic, that was positive to anti-SRP, and afterwards we knew that the anti-HMCCR was another antibody linked or associated with this muscle phenotype. And of course, lastly, the dermatomyositis with antibodies anti-MI2. These other autoantibodies, anti-SAE, anti-TIF1 gamma, or anti-MD5, were not known in 1992. So they helped the clinicians to identify different phenotypes, different manifestations of these different diseases. So these are the diseases of the group. It's an heterogeneous group, and we can define perfectly dermatomyositis, polymyositis, although all we know that polymyositis is an exclusion diagnosis, is very, very rare. The antisynthetase syndrome, that we currently have new classification criteria. And in this box there, we put also other overlap syndromes. Maybe the most known is scleromyositis. We are going to talk about scleromyositis during the next slides. Immune-mediated necrotizing myopathy, that could be with antibodies or without, and the sporadic inclusion body myositis. So let's start with the first one, which is anti-MD5. Anti-MD5 phenotype, this antibody was first described by Professor Sato from Japan, and it's a protein of 140 kilodaltons, and has been related with very specific clinical manifestations. There usually are patients with a clinically amyopathic dermatomyositis, clinically amyopathic dermatomyositis without muscle involvement, or very little involvement, and with a rapidly progressive ILD, interstitial lung disease, as you can see here, with pneumomediastinum and with this severe lung disease. So the antibody, it's a marker of a very severe manifestation of some types of dermatomyositis. Of course, those patients with anti-MD5 positive, not fortunately, not all are with this severe manifestation, and sometimes only arthritis or specific skin lesions that could be very fastidious to treat, such as ulcers, may appear. But the most relevant clinical manifestation is those that affects the lung. So we're talking about dermatomyositis, and if we talk about MD5, we have to talk also with those patients with anti-TIF1 gamma. We have to keep in mind that we are talking today about adult patients. So anti-TIF1 gamma is related with cancer, is a good marker of occult cancer only in adult patients and only in patients with dermatomyositis, not in patients with polymyositis or antisynthetase syndrome. It's a specific autoantibody of dermatomyositis in the adult forms. Although it may appear in juvenile forms, it is not linked with cancer in juvenile forms. So it's very important just to reduce the worries of the parents that are affected, their son or their girl, with TIF1 gamma. This patient here, you can see this heliotrope rash and Gottron papules 2.5 years after development of dermatomyositis, and bladder cancer from urinary bladder cancer appears. This is another case with a gastric adenocarcinoma and positive to anti-TIF1 gamma. And this is an elderly woman with an ovarian cancer. We usually rely, although we know that there are this screening strategy was published in Nature, we participate in this study, but in our clinical practice, we rely mostly on the PET tag and the TIF1 gamma, or the autoantibodies. So the antibody is a good marker for diagnosis of for the screening of patients with an occult cancer. But not only that, but also the anti-TIF1 gamma, when it presents with high levels, could be also a good marker of outcome. So the higher the levels of TIF1 gamma in patients with cancer, the poorer the cumulative survival. So the poorer the outcome. Of course, it happens only in those patients with anti-TIF1 gamma, dermatomyositis, and cancer, not in those patients with anti-TIF1 gamma and dermatomyositis that have not developed any type of cancer. Okay, we have the same results in these two cohorts, that were from our own hospital, Vall d'Hebron Hospital in Barcelona, and also from the Karolinska Hospital with the leadership of Professor Ingrid Lundberg. So this is talking about the cancer and antibodies, a good marker, but recently we have known that other antibodies, as you can see here, anti-SP4 and anti-CCR1, may modulate the risk of cancer. When patients with dermatomyositis and anti-TIF1 gamma positive antibodies develop also or anti-SP4 or anti-CCR1, the risk of cancer decreases. So we have to remember that probably our immune response against cancer, we can know about this immune response because we detect the anti-TIF1 gamma antibodies. And if we detect more antibodies, it means that the response is stronger. So those patients, anti-TIF1 gamma and dermatomyositis, who are also positive to anti-SP4 or anti-CCR1, probably the risk is much lower. Of course, it has been reported in the States, but we are now in the way to try to demonstrate that it is the same in our population. We have not raw data until now. So anti-MD5 with a specific phenotype, anti-TIF1 gamma as a good marker of cancer in dermatomyositis, and this is another phenotype linked to antibody, anti-MI2. This is a typical classical dermatomyositis with muscle weakness, with a muscle biopsy, with perifascicular atrophy, and with this characteristic skin lesions. You can see here the Schall sign on the V sign, heliotrope rash, and also we cannot see here, but for sure with Gottron papule. So it's important because skin lesions here are very common, and these patients usually, in general, have a good response to the immunosuppressive drugs. And the last one of the dermatomyositis is the anti-SAE antibody. There are patients with dermatomyositis, also with skin lesions, more than muscle involvement, and characteristically, they develop this mild form of ILD, interstitial lung disease. It's not so severe as MD5, and it's not so chronic as the antisynthetase syndrome. Other autoantibody that has been linked to cancer in adult patients, I repeat that, it's important, not juvenile. Although juvenile patients may be positive to this anti-NXP2, they are not related, not linked with cancer, okay? This anti-NXP2, it's a good marker also of occult cancer, and also a good marker of these rare forms, which are very severe, with edema in the hands and in the muscles. And this form with edematous dermatomyositis usually also harbors a cancer and are anti-NXP2 positive. Of course, calcinosis, and you can see here, is also related to NXP2, and dysphagia, difficult to swallow, is characteristic also in patients with anti-NXP2. So the antibodies help us to identify some specific phenotypes, clinical phenotypes, to have the suspicion which will be the main organ involved. Okay, antisynthetase syndrome, the characteristic clinical manifestations, you can see here, these mechanical hands, of course, could be also hiker feet, interstitial lung disease, and even the muscle is characteristic with this periatrophic involvement and with necrosis and with the upregulation of the major histocompatibility complex, not only type 2, but also type 2. So it's a disease itself. Antisynthetase syndrome is not longer a syndrome. It's a syndrome because there are signs and symptoms, but we can talk about an individual disease. These different autoantibodies are included in this new criteria for classification, and you can see here this very nice picture about mechanic hands. So we have said before that in the same box we put antisynthetase syndrome and also some overlap diseases, such for example, scleromyositis. And when we talk about scleromyositis, we know that there are some clinical features of sclerodermia and some clinical features of myositis, but there are different types of scleromyositis. And the positivity to the antibodies, anti-PM, SCL, or anti-KU, is very important in this scenario, because those patients are those that are major weakness at diagnosis. There are sometimes skin lesions, typical of dermatomyositis, could be Gottron papules, high levels of CK, and this is an important point, they respond to immunosuppressive drugs. So it's more or less a type of true inflammatory myopathy. But there are other patients with scleromyositis without so important inflammation. And there are patients with not so high levels of CK and negative to the antibodies, okay? The prognosis of those patients, you can see here in these slides, here the inflammatory infiltrate of those anti-PMCL and those with a intrichromic stain. You can see here this connective tissue, very wide here. So this group have a worse cumulative survival, so it's important. In this picture, you can see this inflammation could be the match, and after it burns, it remains the fibrotic manifestations. Okay, let's move to another disease, but with different phenotypes, depending on the antibody. And we are talking now about the immune-mediated necrotizing myopathy that may appear in those patients with anti-SRP positive or anti-HMCCR. These subjects are those who have been treated with statins. So anti-HMCCR and anti-SRP, it's important because in this scenario, it's not absolutely necessary to perform a muscle biopsy. You can diagnose the patients without an invasive procedure, that is muscle biopsy. So it is different in those who are seronegative. It means negative to anti-SRP, negative to anti-HMCCR, and those who are seronegative, it's mandatory for diagnosis to have a muscle biopsy. And more, these seronegative are those who are more linked to an occult cancer also. So we have to remember that point, which is important. You can see here a very nice picture about a patient with immune-mediated necrotizing myopathy with antibodies anti-HMCCR. You can see here these lipid droplets in the red oil stain. These lipid droplets appear because the antibody interferes with the enzyme, with the HMCCR, and the lipid accumulates in the muscle fibers, and perhaps it is some of the reason why the fiber muscles necrosis. Okay, so this is the antibodies identify different phenotypes, and we know, for example, for sure that patients with anti-HMCCR usually responds very well to intravenous immunoglobulin, not always anti-SRP that sometimes need to be treated with rituximab, mycophenolate, or other immunosuppressive treatments. This is a very curious antibody that has been described by the group of Karolinska, by Professor Ingrid Lumber and Dr. Galindo Feria. It's an antibody that goes against this protein, this 4.5 domain. And it's very curious because in the study they found this antibody in polymyositis and inclusion body myositis. But if you study this antibody, you know that 4.5 domain is a gene. It's a gene that is mutated in some muscle diseases that are not inflammatory. I'm talking about Emery-Dreifuss and other dystrophies. So it will be very interesting to know if this antibody was positive in those patients with some type of dystrophy. I know that the researchers have done that, at least in 8 patients, but I think that we have to look for a larger cohort of patients with dystrophy. So it's what we talk, that some patients have a double trouble, have inflammatory muscle disease together with dystrophy features of the muscle. Inclusion body myositis, the antibody that we have for help us to the diagnosis is not very specific. Anti-CN1A, it's positive and may help in a specific clinical context, but it's positive also in other diseases, for example, Sjögren disease or lupus, so it's not very specific, even though may have a role in the diagnosis of patients with a suspicion of IBM. Recently, you know that the hair has no longer been a typical organ involved in, about a myocarditis in patients with inflammatory myopathy, but now we know that not rare these manifestations may appear, specifically in some groups of patients that can be identified by this specific antibody profile. I talk about the antisynthetase syndrome. Probably of the group of inflammatory myopathies are those patients who more frequently may develop myocarditis, acute or subacute, and of course antimitochondrial antibodies, specifically as a cause of arrhythmias in patients with inflammatory myopathies. Several large cohorts initially were reported by Japanese researchers, but we have had some patients in our patient clinic with antimitochondrial antibodies and severe myocardial involvement. So until now we have seen that the antibodies are very important to identify different phenotypes with different manifestations that may allow to the clinicians to define which will be the organ mostly involved, which will be the better strategy, therapeutic strategy for improving their status. So it's important that we have to recognize that, but not only that, and this is not sure, but it may be another paradigm, that the antibodies are the responsible, are the cause, are the culprit of the disease. They go inside the cell, they modify the DNA, they repress some genes, and by transcriptomic analysis we know what is happening at this moment. So this is a very interesting area that probably has to be following in the development. So in summary, we have, you can see here in the puzzle, in the jigsaw, different, we have different clinical manifestations, we have different images, we have also muscle biopsies, and of course the antibodies. It's a part of all this armamentarium for diagnosis, for know what's better, what's happening to our patients, and which will be the best way to treat and to avoid the suffering of our patients. So summarizing the lights and shadows of myositis autoantibodies, we can say that, we have said before, are useful for defining specific phenotypes, and does help a lot to the clinicians. They're non-invasive techniques, it's just to draw the blood. and maybe they help to know about the pathogenesis. There are some insights into the pathogenesis. There are the lights, but not everything is nice. We have some problems with the antibodies. They are limited specificity, not always reliable, depending on the technique. I recommend to read this very nice paper here, published 1 month ago in seminars. It's a study of the IMAX group with the leadership of Takaishi Agono. And in this study, it's demonstrated that there's not a very good concordance in between different laboratories. So this is an important point to address in the near future. Another issue is that it's important for us to know the level of the antibody. Currently, we only know that they are positive or negative, and everybody's talking about the levels of anti-MDA5. High levels means a high risk to develop rapidly progressive ILD. So we need these quantitative results. So I would like to finish my webinar with a question. More than a question, is a reflection. How did we manage before autoantibodies? Think about it. Thank you very much. I will answer any questions you may have.
Thank you very much, Albert. It was great that I was supposed before. We have the first question from Mauricio Cutolo. You know, he always have good ideas. So he asked, do the several autoantibodies found in myositis can be considered more functional, so involved in pathogenesis more than only markers that we have did so far?
Mauricio, as always, you are right. I think that probably it's true. So it's very important. I am sure that all the clinicians that has been treated those patients the last 20-25 years have the same experience. The antibodies, when the patient is doing well, disappear. Most of them disappear. The anti-MA2 is not longer there, had disappeared. It's another issue that supports the idea that the antibodies are pathogenic to these diseases. So I agree absolutely with you, Mauricio.
This is very interesting because so far we consider that just markers. And I was going to ask you about the technique to detect these antibodies that you already mentioned, because we know that, you know, nowadays what we have is all these techniques which are usually multiplex assays, and these are not very well standardized in such a way that every commercial mark makes their own multiplex. So they put the amount of antigen they want and the different antibodies. What do you recommend? Because we all not have access to immunoprecipitations which is the best, but we don't have this. So what do you recommend in the clinical settings of most of us?
In the clinical setting, you more or less do what you can do. So you have not too many options. But if it's possible, some antibodies, it depends on the antibody. For example, anti-TIF1 gamma, it works very well in the ELISA MBL. But what happens that ELISA, it's not possible to perform only one patient. There are 96 wells. It's for 45 patients. So the laboratory is going to say to you, no, we can waste one full ELISA for one patient. It's cheaper to do one immunoplot with TIF1 gamma, but it doesn't work so good. So we, in our clinical practice, we have a homemade TIF1 gamma by ELISA, our own ELISA and our own immunoplot that has been validated in the past with immunoprecipitation studies that we have performed more than 10 years ago. So we more or less behave in this way, no? I strongly recommend to read this paper of the seminars because it tries to address this problem, and probably there is a lot of work to do. And I know that Sarah Tansley in Bath with McNeil also, they're working together to try to homogenize to solve this problem.
Well, the same is what is with the ANCA antibodies, which is standardized now. We have many questions. So we start with Javier Garcia, who asks, in a patient with dermatomyositis and TIF-gamma positive and no evidence of cancer, including PET tag and no symptoms, will you repeat any diagnosis workshop? So when, just if symptoms appear, what do you think about that, which is very important for our patients?
See, it's a very nice study in United Kingdom that demonstrates that after 3 years, the risk of patients with dermatomyositis and TIF-1 gamma is the same as the general population. So after 3 years have passed, be quiet, no problem. The first 3 years, we usually recommend a PET-CT every year, 3 times. First year, second year, third year. And of course, when we see the patients in our outpatients clinic, we explore the patient, we ask, and we have the special sensitivity and all the screening tests, fecal blood test and mammography has to be performed in the same way that in the general population. So we have especially to be aware, but sometimes it doesn't appear, never. We have some patients with anti-TIF-1 gamma more than 15 years ago, and the antibodies, in this case, some of them are positive, but there is no cancer. So not 100% of TIF-1 gamma patients have a cancer, which is in the same line with these antibodies. We don't know if these patients who they are talking about are positive also to anti-SP4 or to anti-CCR1, because we haven't tested yet here in Barcelona. We're in the way to do that.
Okay. Next questions, which is very important regarding the techniques. Are false positive immunoblotting results observed?
Yes. Yeah, yes. But I think that a good strategy when you are talking about antibodies and myositis is the pretest probability. The same when we are facing a patient or seeing a patient that you think they have a pulmonary embolism, and it depends on a lot of factors that is saying to you that the risk is high or not. So if I am asymptomatic and you ask me anti-1 gamma and it's positive, one cross positive, of course it makes no sense because I have not a dermatomyositis. Now.
But for a person with dermatomyositis, Elizabeth is asking, a person with dermatomyositis can, if it is in your experience, have you found immunoblot results which are false positive?
Yes, sometimes yes. This is when
we need the standardization, I think.
Yes, of course. We are trying, but we don't succeed. We are trying to buy MBL. MBL is doing very well. It's an analyzer and has been tested against immunoprecipitation with Lisa Castiola-Rosen has did this work. So it seems that immunoprecipitation and MBL, that's an ELISA for anti-TIF-1 gamma, match 100%.
Okay.
Blood not. I agree with you. We have some problems with the blood with autoimmune or other types of blood anti-TIF-1 gamma. And we have some doubts of, for example, if you have anti-TIF-1 gamma and also anti-PMSCL and anti-LA, a lot of autoantibodies, you are thinking probably it's a multiple.
Something is wrong.
Positive, yeah.
We have another question. When you said it's less specific, do you mean it could be associated with other diseases than different from inflammatory myopathies?
We are talking about IBM patients?
Talking about general, there's some antibodies which are less specific.
It depends. Less specific means specifically in those patients with anti-C1NA, which is a marker of IBM, but can appear in other diseases. When they say less specific means more or less the same idea of false positive. It means that it's not detected the true antibody, which is linked to cancer.
Okay. And Mauricio continues asking about this functional. In the case that the antibodies have a functional role in the pathogenesis of the disease, should they be a target for future monoclonal therapies personalized on the type of myositis that patient present? It's like a good idea to focus on this.
Well, Mauricio, is a difficult question. I don't know.
Yeah, as an idea.
Yeah, of course. Why not?
Why not? To know more about that. But
I don't know. I have not rationale to that. Sorry.
Well, but if they are pathogenic, we can target that in a moment. Okay.
We know that after COVID, we know that mRNA vaccines may help also to fight against cancer antigens. These vaccines that are not vaccines, but vaccines against tumoral antigens. So in the same idea, probably it could be also against Jo1 or against PMCL or HMCCR. Why not?
Okay. There is another question, and someone is telling that we have to finish. Could antibody titers be used to stratify disease activity, low, moderate, or severe in specific phenotypes, not perhaps in all, but in some specific phenotypes?
That's a very good question. For example, the anti-HMCCR that is used by the own LIA, it's possible to give some values that goes from 0 to 300. And in these cases, there is a very good relationship between the level of the antibody and the CK and the clinical grounds. So in patients with immune-mediated necrotizing myopathy by statins and HMCCR, the answer is yes. There is a previous article more than 20 years ago in anti-Jo1, and they found also that there was an activity was linked to the level of the antibody. But the main problem is that most of the antibodies that we determine in clinical practice, we don't have the level because
we have positive or negative, right? That
it's not quantitative, and it depends on the technique. HMCCR uses a technique that may allow to have this level of the antibody. The others, you need ELISA. And as I have said before, ELISA is not only, you can do only one patient with ELISA, it makes no sense. It's too expensive. You need to perform 20 patients, 30, and it's a rare disease. You have not 20 patients to be.
You don't have so many serum usually at the same time. And when talking about false positive, the same person, Elizabeth, asked, what about the value of positivity in immunoblotting?
I think, Elizabeth, that it is the same that we have said. Is the positivity, it's important if you are seeing a patient that it matches with what you are thinking. No, you have a toxic syndrome and dermatomyositis with a breast tumor, anti-1 gamma, very positive. Okay, of course, it makes a lot of sense. You have sometimes from dermatologists, they send patients with anti-1 gamma, but they have not a dermatomyositis. They have another psoriasis or other type of skin lesions. So then it makes no sense to ask for antibody. Some years ago, the oncologist performed to all the patients with cancer anti-1 gamma. And usually they were negative, but maybe 1 in 100 was positive, but there was not a dermatomyositis. So it was a patient with a false positive, probably.
I have a question myself, which is important for me. In MDA5 patients, we are always, so scared about the ILD, progressive ILD, very rapidly. But not all, the same, not all TIF gamma are positive, have cancer. Not all MDA5 develop rapidly progressive ILD. What is more or less the percentage of patients? And what do you do with the patients that you have with MDA5 without respiratory symptoms? Because for me, it's something you are always scared, and you follow the patients very carefully. But perhaps we don't have to do so.
That's a good question, Patricia. It's a very nice paper from the group from Paris, Allenbach and colleagues, that they define in more than 100 patients with anti-MDA5, they define different phenotypes. And they say there are some patients that only develop skin lesions, severe skin lesions with ulcers, but not develop lung disease. Others, this typically rapidly progressive ILD, and the others, some manifestations, rheumatic, they say, manifestations. So it seems that, for example, the value of the capillaroscopy or also Raynaud phenomenon on the show goes more to those patients with skin lesions, but nobody knows exactly which will develop or not at the onset. So we usually perform functional tests, respiratory functional tests, and one time at least CT scan, and we are aware about the outcome of the patient, very close to the patient. If a month, 2 months, 3 months have passed and there is not involvement of the lung, maybe this patient will never develop. We have had patients with anti-MD5 without lung disease, and more than a year after, the antibody had disappeared and the disease disappeared also. And the disease was there. We have capillaroscopy and we have had muscle disease, but we don't know why. But they didn't need more immunosuppressive drugs. It's very curious. It's some type of dynamic disease.
Yeah. So we are very, very practical issue. So if within the first year the patients doesn't develop ILD, then you stay more or less. Never in medicine is everything like white or black, but more or less more.
If you have asked this question to me 3 months ago, I definitely said, don't worry, 1 year after never will appear rapidly progressive. But we have had 2 patients that more than a year after had developed a rapidly progressive interstitial lung disease, and very severe. One has been transplanted and the other is not very good. So we actually don't know too much about these diseases. We have to perform research and to share our clinical experience just to try. These are rare diseases. So
it's rare.
Are few patients.
People, thank you very much. And this is the time for just the last question from Lina Diaz, which says, so what would be those anti-TIF gamma would be doing on those cases where not myositis is present? Are they part of the normal response of the body to control cancer or infections, and they get crazy in some people and other with other predisposed factors?
Lynn, I don't think that there is a marker of cancer. I don't think so. So
okay,
false positive, and we don't know exactly. When you have to keep in mind when you are doing an immunoblot for TIF1 gamma, is not the full protein. It's a piece of the protein, so it may react with other antibodies or other immunoglobulins. So again, you need to match the clinical scenario with the antibody. If not, it makes no sense. I think that the very important issue of the antibodies is because they are marker of typically manifestations of some people. We had described an antibody. We thought that was very important, anticortactin antibody. We have published several papers, but it makes no sense because it's not a good marker of nothing. So it's there, and it doesn't help the clinician.
Well, I think with this we have to finish this interesting section. But thank you really very much. A lot of people thanks you from many places around Europe. So thank you very much, Albert, and thank you to Reconnect to allow us to perform this
thank you,
webinars.
for your kind moderation.
So,
Okay,
bye-bye.
bye.